Hello and welcome to everyone today for our first Inside APSAD webinar for 2025. My name is Jeff Buckley. I'm the Director of Insight. It's my great pleasure to welcome you here and to Zoe Walter, who is our first speaker. Hi, Zoe. Before we begin, I'd just like to acknowledge the traditional custodians of the lands on which we're gathered here in Meanjin in Brisbane on Yagara and Turrbal land, but to all of the lands and waterways across Queensland and the country for where learners or participants might be joining from us today, and paying respects to elders past and present. I'd also like to recognise the lived and living experience of people who we work with across all of our kind of areas of work, and their families and carers who contribute towards kind of reducing harm and recovery journeys as well, and it's the reasons why we are all here. Now, it is our great pleasure to have our first webinar. As I mentioned, we have Zoe Walters here from UQ. And I'll just bring up, Zoe is a senior lecturer and researcher in health psychology at the University of Queensland. And we'll be talking about from data to impact, examining predictors of outcomes in AOD treatment. And we appreciate you joining us here today, Zoe. I'm sure everyone's aware in Brisbane, we are gearing all ready for Cyclone Alfred to descend. So this may be our last day before we all race home and batten down the hatches. But thank you for joining us, and thank you to those for whom that may have impact. But I'll throw it over to you, Zoe, to do this. And if anyone has any questions along the way, please jump them in the chat and I'll ask Zoe at the end of the webinar your questions or your comments. So thank you, and over to you, Zoe.
Thank you so much for that introduction, Jeff. I would also like to acknowledge the traditional owners of the lands in which we're meeting on today. As Jeff said, I'm a Meanjin country, and so the Yagara and Turrbal peoples. Pay my respects to ancestors and their descendants who do continue to have that cultural and spiritual connection to country, recognising these lands were never ceded. And I'd also like to pay my respects to all the lands in which our participants came from, and their lived and living experiences involved in this presentation that I'm about to provide. I'd also like to thank the research team behind all this research that I'm about to present. So the UQ team and the National Centre for Substance Use Research team, which is based at the University of Queensland, as well as the Lives of Well team who we've partnered with for these projects I'm about to show you today. As Jeff said, I'm a senior lecturer at the University of Queensland, and a lot of what I'm interested in is the combination of really theoretical and applied research to really translate different types of interventions into practice and really try to understand how we can improve that implementation process, particularly for understanding the health and well-being of a range of different groups, particularly people who are experiencing substance use and drug and alcohol practice and issues, but as well as other marginalized groups as well, people who face stigma and discrimination in so many different ways of their lives. So that's really what I want to kind of talk about today, is the projects that we've done where we're trying to translate that research base and the theoretical underlying of it into practice and policy. So across a few years, we've worked on a few projects with Lives of Well and the NICER team at EQ. And that's what I'm going to talk about today. So we did one project which was looking at transdiagnostic cognitive behaviour therapy as a telehealth program for comorbid mental health, particularly for people aged 16 to 35 who are entering substance use treatment in community and residential services. We also looked at a project which was a resilience-based project to increase social and emotional well-being in people entering residential AOD treatment. And a trauma-informed care model that kind of was followed on from that GRIP project that was looking at introducing a full 6-week model that was really based on trauma-informed care principles in one residential AOD treatment service. And a lot of what our main focus is when we do these projects is trying to understand what is the feasibility of these projects. So is it something that we can run in practice? When you do run it, what's the acceptability of that to clients, to clinicians? What does that look like? And the effectiveness of these interventions. So do they do what we set out to do? And that's what's presented on a lot for these projects. So at APSAD and different conferences, we've written that up in research papers. But a side question that maybe shouldn't be a side question that I often have when we do these projects is not just what is the effectiveness and feasibility and acceptability and those kind of core questions, but what else is having an impact on these treatments that we're not thinking about? And really that's to inform what can we do better next time. And this has been a question in this sort of research for the psychological therapies for a long time. So this quote is one of my favorites. It was said in the 60s by Gordon Paul, when he was talking about evidence-based interventions, which is not just what's the effectiveness, which again is a lot of what we focus on, but what treatment by whom is most effective for this individual with that specific problem, under which circumstances, and how does it come about? And so that's the kind of question I'm going to start answering in some very small areas today, where across these three projects, I've looked at what are different predictors of treatment outcomes. So when I'm talking about different predictors, the main three predictor areas I've looked at, I and research students and the bigger team as well, I should say, are more individual level predictors, as well as treatment related predictors and broader social and environmental level predictors. So when I'm talking about individual level predictors, these are things like demographics, which is pretty straightforward. The main ones I've looked at are age and gender, as well as the kind of severity of the presenting problem. If you're talking about it in that more CBT psychological talk, it could also be what other comorbidities people have, or just their outcome measures, another way of thinking about it. So the ones we've looked at is depression, anxiety, as well as AOD use, the comorbidity between those factors, as well as polysubstance use. And the third area of individual predictors I've looked at is those mechanisms or transdiagnostic factors, or going back to the Gordon Paul quote, the how does it come about kind of question. So some of the ones we've looked at are automatic thoughts, coping skills, emotion regulation. For treatment-related factors, what I've really looked at here isn't very much. There's a lot that can go into this. The one thing we've looked at is therapy characteristics, so the concurrent treatment and treatment intensity, as well as therapist characteristics. And this one's been studied a lot across a whole range of different areas, and it is really critical in terms of understanding the effectiveness of intervention, is that there is that baseline of therapeutic alliance and working rapport there, above and beyond which then we look at what effects happens with which individual intervention we run. And some areas around service details like location or access to service. And when I'm talking about social factors, the two main ones I've talked about, I'm going to talk about today, is social connections and network and social support. And when I'm talking about treatment outcomes, that's a really broad term as well. And some of the things we've then looked at is treatment initiation, as well as treatment dropout or engagement, and then the outcome measures that we've used. So again, AOD, mental health wellbeing, and those transdiagnostic factors. In terms of how we actually measure those outcome measures, primarily what I'll be presenting on is really the WHO assist when I'm talking about AOD use and related concerns. PCR5, if I'm talking about PTSD, I'm talking about depression, that's typically the PHQ-9, and anxiety, I'm talking about the GAD-7. Okay, so I'm going to just throw a lot of like what I've found in terms of these predictors out at you. So the first big question we had when we're talking about do these interventions work is there differences for when people come into the service on their baseline levels of how that actually leads to their treatment outcomes? So do people who come in with more severe levels of substance use have better or worse outcomes? Similar for depression and anxiety and trauma. What we've found is that baseline depression, baseline anxiety, and baseline PTSD symptoms and their primary substance of concern isn't actually predictive across those three studies where we looked at this of those treatment outcomes. So higher level low levels of these didn't actually impact the treatment initiation, engagement, or those treatment outcomes in terms of how they responded to being in the service. What we did find was polysubstance use did predict things like treatment outcomes and treatment completion, as well as the WHO assist total scores, which again is probably more representative of that polysubstance use. So when we look at one of the things in terms of completion versus not, you can see that the higher those baseline levels of the WHO assist were on entry, the more likely they were to not complete treatment. Similarly, when we look at their primary substance of concern, I did say this didn't predict it. That's because in one case, opiates and other sedatives as a primary substance of concern did predict change, but that's because they were just higher at the outset and they had a higher rate of change. And I think that's not necessarily because of the primary substance of concern, it's because they were the most likely to have a polysubstance use profile. So people who came in with those higher assist were more likely to drop out of treatment, but people who came in with those higher assist scores also were still likely to come down to the same level as everyone or have a higher rate of change at 12 months. They were still slightly higher than others at that 12-month period, but the rate of change was actually greater. So they were still higher at 12 months, but they did have pretty good outcomes relative to their starting point. You can kind of see we didn't find anything for depression in terms of if it was minimal, mild, moderate, or severe. And similar for anxiety, we find a similar pattern where that rate of change is about the same across those groups. In terms of individual factors in demographics, we found that we looked at things like referral source wasn't related, gender wasn't related, and age in the residential services is not related to treatment outcomes. However, age did predict treatment initiation and engagement in those community settings. And treatment outcomes, including outcomes on those primary measures I showed before, was predicted by having children, which I'm not going to go into because I think that's pretty straightforward. But I will focus on the age question because we found this really interesting phenomenon when we were doing that first study in the community, where we were trying to look at specifically young people. So the project was initially just for 16 to 25-year-olds, and we found that overall fewer young people in that age bracket accessed the service straight away. So there was 290 young people when we did this over a 2-year period accessing these services in Southeast Queensland, and that was compared to 435 older young people, so in that 26 to 35-year-old range. Once we actually got a hold of them, fewer were eligible to be contacted for whatever reason. Either they didn't want to be contacted or they weren't meeting the criteria for baseline depression and anxiety, which was what we were interested in for this study. We also found that they were more difficult to screen, just a little bit. So we found it harder to get them on the phone, harder to complete that first initial consent call with them. Once we did complete that, there were fewer that were actually eligible for inclusion in that comorbid transdiagnostic study. And again, the main eligibility criteria was that they were meeting a certain threshold for their WHO assist score. So it had to be above mild levels for the WHO assist and depression or anxiety or PTSD. Once they were eligible, few actually completed the baseline assessment. So we'd call them up, we'd screen them. If they were eligible, we'd send them out a study link, and fewer completed that, even though we had much higher contact attempts for that younger age group. So we thought that's pretty interesting. What's going on for these young people? Where are they coming from? So we also looked at the referral source. This graph is showing the absolute numbers, but what's probably better to compare is the percentages. So we found that fewer of those young people were self-referred compared to the 26 to 35-year-olds. It was about equal for referrals from health services. So this is from other services like Queensland Health. They were higher on referrals from justice systems, so that would include things like drug diversion programs, but also just referrals from police. And there were also higher referrals from other referral sources, which is a pretty broad category, but the majority of those in that 16 to 25, it was mainly 16 to 18-year-olds. There was a lot of referrals coming from schools. So we did find that they were really quite different entry points into these treatment services for those young people. And referrals was in and of itself didn't then predict anything, but I think it was just interesting to look at where are these people coming from. And as I kind of mentioned, we found that young people were more likely to not even come to that first session of treatment, kind of matching on the drop-off we saw across the whole project with the referral scores. So 35% didn't even start treatment, compared to 22% of that 26 to 35-year-old cohort. We also found that they had a lower number of sessions on average, so they were less likely to complete. And for this Fullworks project, the transdiagnostic CBT program was 4 core sessions, and then they could do additional sessions for a stepped care approach if they liked, or as well as case management and treatment as usual. But these number of sessions are specific to the full fixed transdiagnostic CBT one that I'm talking about. We found no overall effects of age on treatment outcomes, which is similar to those other studies in the residential services I was talking about. But we did find something interesting where younger people were more likely to report cannabis use as their primary substance of concern. And then when we look at just cannabis use for their WHO assist score, they actually had higher rates. Even if it wasn't their primary substance of concern, they actually had higher rates of cannabis use. And they had a bigger drop off in that cannabis use compared to the older cohort, which again is an older 26 to 35. So age was an interesting story just for this community sample. One of the other big questions in individual factors was also looking at those, what I was calling transdiagnostic or process variables. What I mean by transdiagnostic approaches is just what are those common underlying risk factors that may underlie both substance use and mental health concerns or a range of different areas. The projects that I presented are based on some core transdiagnostic processes, which are emotion regulation, impulsivity, and social connectedness, group belonging, which I'm going to talk about later. And one of the things we were really interested in is not just do these interventions work, but do they actually target the things that we said that they target? So the measures that we looked at, I also looked at cognitions in terms of automatic questionnaire. For impulsivity, we looked at the SUPS, which is a measure that breaks down impulsivity to these different dimensions, including negative urgency. So when you feel like negative emotions, you do things that are impulsive to reduce that level of uncomfortableness. Positive urgency, it's kind of like the flip side. When you're feeling really good, are you more likely to be impulsive? Lack of premeditation, so you just do things without thinking. Lack of perseverance, so you start things and not follow through. And sensation seeking, so you're going for that kind of adrenaline rush. And emotion regulation, we measured using the DIRS, which is the difficulties in emotion regulation scale, which breaks emotion regulation into these kind of components. So the non-acceptance of emotional responses, as well as difficulties in engaging in goal-directed behavior, impulse control difficulties, lack of emotional awareness, limited access to emotion regulation strategies, and lack of emotional clarity. So we've looked at this across those 3 studies and in different ways. We found overall that our process variables did change, as well as the outcome changes. So that was really nice. We said we were targeting these things. They did actually reduce over the course of treatment. So yay. We were also interested in if these changes then predicted subsequent changes in our outcomes that we were mainly interested in. So the substance use, depression, and anxiety. For cognitions, we found that it didn't actually predict substance use outcomes. So those negative automatic thoughts, or those unhelpful thoughts that people come, which we were targeting mainly in full fix. But it did predict depression and anxiety. We also found that baseline level of negative cognition, so the higher levels of negative automatic thoughts you had at the start, didn't have any relationship to whether they responded to treatment or not for substance use or anxiety, but we found it did for depression. In terms of those impulsivity, very similar story. change in levels of impulsivity, and again, this was explicitly targeted in a lot of our interventions, did predict changes in substance use. It did predict changes in depression and anxiety as well. But we found that baseline levels of substance didn't actually predict those changes in substance use, depression, or outcome. So having higher levels of impulsivity at the start didn't impact whether people responded to treatment, like have a bigger or smaller response to treatment. We then looked at this for emotion regulation, and this was an interesting one in a lot of ways. So we found that there were some changes. So changes overall and difficulties in emotion regulation did predict treatment outcomes. We found inconsistent results of whether baseline levels of difficulty in emotion regulation related to treatment outcomes. So we found initially there was no relationship to substance use, but in some cases there was like a slight negative correlation. And we found that in some of our studies, baseline levels of DERS did have an impact on depression and anxiety outcomes. So we wanted to explore emotion regulation a little bit more because it's actually quite, as I showed, a lot of things going on with emotion regulation. Like it's not just a one-dimensional concept. So we broke it down into the subscale measures to try and understand what might be going on. And what we found was that people who had higher levels of reported difficulties with strategies and tasks were actually more likely to engage with treatment and initiate treatment, and were more likely to have those positive associations with changes in substance use and changes in depression and anxiety. And that was related to, they had higher levels of difficulty at the start, but then they had a higher rate of change with those difficulties. So they had a high level of improvement in their emotion regulation. But when we looked at difficulties with awareness, and in one of the studies already as well, awareness was a more consistent predictor, we found that people who had higher levels of difficulties with awareness of emotion were less likely to engage with treatment and less likely to initiate treatment. In follow-up work, we did actually talk to people as well around what were the barriers. And this actually came up as a theme in participants' qualitative responses. So they'd say things like, I could have been more open and talkative about it, but I just didn't want to. I'm not the type of person to talk about that. So I'm not that type of person to actually talk to people, like open up and stuff. So they just saw themselves as, this is not for me. Talking or being open with my emotions is not something that I want to do. And these participants reported that as a barrier to wanting to engage with treatment. Which does lead me to my next area that we were kind of looking at, which was treatment factors. This is such a huge category, but the two areas that I'm going to talk about is treatment factors in receiving integrated care, and that qualitative study where we were really trying to delve a bit deeper into saying, okay, like we have these difficulties with engaging with treatment and we know there's lots of barriers. What are people actually saying about these treatment factors when we talk to them? So in that first area, the receiving integrated care, this came in that final project I mentioned where we're talking about trauma-informed care. And when we started this project, we did it as a co-design approach, and as part of that, we spoke to both clients and staff around what their views were on trauma-informed care and trauma-focused therapy. What we found was that they perceived residential services as being a safe and supportive environment to receive this sort of not just trauma-informed care, like they really wanted trauma-informed care, but also trauma-focused therapy, where for people who were coming in that had that past experience of trauma, they saw this as something that was really key to address in their substance use treatment. And both clients and staff said, yeah, if we did address this together in an integrated approach, we think it would have better treatment outcomes. But they also did raise concerns about how trauma-focused therapy, as opposed to just taking a broader trauma-informed care approach, would impact staying in treatment. So particularly staff saying, we think it's a good idea, but we're just concerned that this may impact, if they're receiving this, bringing up this trauma once we've already taken away their primary coping, which is substance use, it's going to be overwhelming and they're not going to be able to manage to stay in treatment service. And that's a really legitimate concern that we're like, yeah, we want to be looking at this. So when we did our trauma-informed care model, we actually had a subset of clients who had trauma symptoms who, in addition to getting the trauma-informed care alone, got a trauma-focused therapy, which in this case was cognitive processing therapy. So it has a basis in CBT. So if you see on my next slide, CPT, that stands for that trauma-focused approach of cognitive processing therapy. So we were really looking at how does this impact their treatment received? And what we found was it actually had a positive impact on how long they were staying in treatment for. So for people who were receiving that cognitive processing therapy alongside the broader trauma-informed care approach that the service model had, they were staying in treatment for a longer period of time for their first admission. They also had a longer total number of days in treatment. They had fewer readmissions. So that kind of going in and out less times. And they were more likely to meet what we consider the criteria of treatment completion. And I should say this is our study treatment criteria of treatment completion, which was, did they complete the 6-week program, which is different to, say, that what you actually may do in practice, which is, has this person had a perceived readiness to finish treatment as seen by the client and the staff. But we have to define this in something for our treatment outcomes. So that was considered 42 days. And they actually had a much higher rate of like, yes, they are completing treatment as per getting that full 6-week program. That's what we mean by that. I don't actually have this on the slides, but people who received CPT as well as the trauma-informed care actually did have a greater reduction in their trauma symptoms compared to people who were just receiving the trauma-informed care approach. So the next question we had around treatment factors was, well, what are those treatment factors that clients actually say are coming up with? So we did some qualitative interviews just on that first project that I talked about, the transdiagnostic CBT program. And this was for people who were both in the full fixed program as well as in the usual care. We were just interested in it broadly across both. After we finished the intervention and the evaluation phase, we contacted a subset of participants to take part in qualitative interviews. We tried to get an equal split of that younger group, the 16 to 25, and the older group of participants, the 26 to 35. And we really purposely sampled to get an even range of levels of engagement with treatment. And we actually did get a pretty equal split of people who got no treatment, who got 1 session of treatment, and who got a fair bit of treatment. So I'm going to focus in on barriers of treatment. We found a lot of other themes as well. But I'm going to focus on those barriers of treatment-related factors. One of the first things, or the first thing we found, was that service access was just a really big thing coming out. And out of service access, 2 of them was a lack of access, as well as competing priorities. I've kind of worded this as the negative forms of these themes. I should say for a lot of people, they also reported positive things, like it made it really easy to access it. The opening hours were really available to me. Being able to do it via telehealth was really helpful because I could access it anytime. I could do it after work. So apologies that I was worded it negatively, because we did actually find both those positive and negative aspects of those things coming within this broader category of service access as being really critical. So one example of that lack of access was I just moved to this town and I didn't have a license at the time. I couldn't drive out there. And I think she called me to make an appointment, but because it was 45 minutes away and only by car, I didn't have any way out. And again, the opposite side of that was people saying like being able to do it in flexible ways really helped. The competing priorities was things with work and other family commitments and other commitments that they had on. So things like it was hard, like with work and that as well. I was missing a lot of appointments, and yeah, we just ended up pulling it off. Like I understand where she was coming from. I was pretty much wasting her time, not being able to shop because I was working or I was at the doctor. So as well as that, the second theme to come out was really more related to the idea of treatment in and of itself. And the interaction of a person's state of readiness, as with what treatment was available and offer and how they matched with that. So really that combination of the individual and client where they're at and the therapist and the therapy that was offered to them at the time. So one of the themes was that avoidance of it, so just not wanting to engage because it wasn't a good fit or it wasn't a good match. So things like I probably would have just stopped going because I went out for the weekend, got really fried or something, and then just felt really shitty and probably didn't want to go back because it'd be a mess up later. So again, these things aren't just at an individual level, it's that combination of the individual interacting with the approach and her lack of rapport. And as I said, this is all kind of worded negatively. We found a lot of these sub themes, but positive side of it as well, like the importance of rapport, the importance of that being the treatment approach matching the person's approach. But in terms of lack of rapport, it's sort of like a big step to do that. If you find yourself with someone who doesn't actually, like, lady, you're not listening, that's enough to shut someone down and put them into U-turn. And treatment goals. And again, for this theme, we found both sides of the coin. So people saying, what really helped me was the treatment goals, or treatment goals match my goals, really helpful. But on the flip side, some saying there were some goals set, but a lot of it was pretty remedial goals. I just wish there were some more important goals. I wish I had more advice, more long-term goals. And the longevity is going to expire if you don't think of the future and stuff. So the final area of predictors that I've looked at across these three projects is the social factors. And as I kind of mentioned at the start, this is one of the transdiagnostic or process variables I'm really interested in trying to understand how these shift and how the shifts in these areas relate to treatment outcomes. The basis of that approach that we've taken in those three projects I showed you at the start is the social identity model of recovery, which is based on the social identity model of identity change, which is really just saying there's a shift in identity from being, say, a substance user as a way that you see yourself and that the groups you belong to revolve around substance use, to shifting to a more recovery identity. And this has been particularly looked at a lot in residential services because that sense of identity in groups is surrounded by the environment as well. And having that shift in identity from, say, this is my using group, and I have a few non-using groups, and I have a few different forms of identity, but they're not a part of my life compared to these groups, to being a recovery model, where it's, say, I see myself as part of my recovery group, I see myself as part of my family group, I see myself as part of these other groups. And that shift in balance is something that can go from recovery initiation to recovery maintenance. So we're interested in looking at some of these processes. Well, I guess that's the basis of what we try and target in our interventions. So some of the things we've looked at across, and I think this is averaged across those two residential projects I talked about, maybe also fulfill, which was, what are their groups when they're entering into these treatment, and how does it shift over time? Are we seeing a shift over time? What we found is that, yes, in general, we do see a shift. So these are the percentages of people reporting their social connections over time. So at baseline, 50% reported that they had a friend group, 60% reported they had family, and then other groups were kind of less. So were community and recovery. Zero recovery sitting at 10%, and this is all people who were in a treatment setting at the time. You can see at 6 weeks, work, friend, family, work, and community all have that upward shift. And that does go down a bit at 3 and 6 months, but remains relatively stable over time, with some groups kind of continuing to increase, like work. when we look at just total number of groups, so these were just categories that people chose, we found a similar kind of upwards trend. So over time, there's this upwards trend of people joining more groups and having more groups as they're kind of going from baseline 6 weeks, which is when they're finishing their treatment in the service typically, to 3 months, and that more 6 months and 12 months of maintenance or post-treatment. We were interested in like the similar process mechanisms I reported before. So do these things actually predict? Do changes in these areas of total groups and social support actually predict their outcomes? So we found that change in social support did predict substance use. So the more social support people reported having, both at baseline and over time, predicted a greater decrease in their substance use over time. But total groups didn't have any effect. We found the same pattern of results for mental health. And we were interested in trying to unpack this a bit further. So we looked at the relationship between total groups and social support, and we found that the more groups people had and joined over time, the more social support they were able to have. And then the more social support they were able to have, the lower their substance use was over time, and the better their mental health was over time. We unpacked that total groups a bit more because if you remember that kind of social identity model of saying it's the shift in groups, not just the total number that's actually important. And that's also what we found. So we found that when you account for social support, if you do belong to family groups and have that change in family groups over time, people generally found that was related to greater levels of social support. But the link between friendship group and social support was more variable. So in a lot of cases, we found that there was no relationship with social support. In some cases, we found there was actually a negative relationship when you account for, say, positive aspects of social groups. So when you're taking out some of the groups that provide social support, the friendship groups who remain actually have a negative impact on the participants' health and well-being, in terms of their substance use and their mental health, depression, anxiety. So I've just thrown a heap of information at you, and I realize I often do talk quite quickly these sorts of things, so apologies. I just want to break down a kind of summary of those results. So in general, what we found was when we were looking at those individual factors, what was really important was levels of polysubstance use. Having lower levels of polysubstance use and substance use severity at the initial treatment predicted treatment completion. And I guess on the other hand, higher rates of polysubstance use predicted greater rates of dropout from services. But we didn't find much in terms of other demographics, including baseline mental health symptoms in terms of those treatment outcomes. We did find that for community services, younger people were harder to get into treatment. And I should say we may find this as well for the residential services, but we don't. But I think it's the way the project's set up is that you're not capturing that information in the same way. Because when we're doing those projects with residential services, we're getting people once they're already at the point of entering the residential service. That's when those initial baseline conversations happen and when we do the consent process. And so it's probably, I would think, just based on anecdotal evidence and chatting with people in the sector, those younger people are also probably as difficult to get into the residential facilities, and the drop-off probably also happens there as well. But I guess the story is for residential services, once you actually get people into the service and they're in the residence, they're not more likely to drop out based on what we found across these two studies. So obviously not something that's generalizable. Our process variables, so those things that we were trying to target in our interventions, were predictors of treatment outcomes. But the actual understanding of how and why these treatment outcomes were being impacted by these process variables were more nuanced. And so that really does feed back to us, me as someone who's delivering this treatment and thinking about how we can do these programs more effectively. A lot of what we're trying to do with the approaches we're taking is to say, hey, here are different strategies that you can use, and what strategy is most useful to you as an individual based on these areas that we know are concerns in general. In terms of treatment factors, I don't think I've actually reported this, but we did find that people who completed treatment had better outcomes across the board in terms of their substance use, mental health, and well-being. That one area we did look at, which was with people who had the trauma symptoms and they received trauma-focused treatment, they did receive they had higher levels of retention at the service. They were more likely to complete that treatment, and then they did have better treatment outcomes as well, which is suggesting, as I said, kind of all that focused treatment can help. And this is something I guess that everyone probably already does know, but our qualitative interviews do show that kind of critical role of the approach matching a client, and the importance of therapeutic factors in our treatment. So regardless of these interventions that we're doing, we can't ignore that the therapist is still at the heart of that, and is so important to whether a person is finding it a helpful or not a helpful program. And in terms of our social factors, we found there's changes in social support and groups. Again, that target of a lot of these programs did happen and were maintained over time. And that social support was a predictor of treatment outcomes. But in a lot of cases, it depended on what group it was. And so the groups that were particularly beneficial that we found was the family. And I think further work does need to be done on like how we can actually incorporate this more in treatment in terms of identifying unhelpful groups and how this can be targeted. Implications. I think it's important to understand. What factors might have that impact on treatment and why. And in particular, that we can measure that. So that we're understanding, not just is this treatment effective, is it feasible and acceptable, which is important, but also the who and the why. So how is it effective? Why is it effective? For whom is it effective for? And really that's so we can adapt and improve our programs. So some of the questions that kind of came out of this research for me was, okay, so how do we better engage these young people at all stages? Or needs that specialized support more helpful than others? And when do we target these transdiagnostic and process variables in treatment? So for example, that finding that we had with emotion regulation is suggesting that, if you're trying to target emotion regulation, it's important to have the right goals and strategies and work with people who are saying like, yeah, I recognize I need more goals and strategies. And a different approach may be needed for people who are saying, actually don't want to talk about emotions at all. And so trying to lump them together and under one intervention that just targets emotion regulation isn't going to be helpful because they're quite separate areas in terms of the potentially underlying motivation and the way in which you want to work with a person who's coming to you with those as kind of areas of concern. For me, it's also about moving beyond those traditional measures of treatment success, really looking at across multiple life domains, as well as looking at those other aspects of treatment. Again, a lot of our interventions and looking at those outcome measures. But a lot of what I was doing with looking at these predictors is more what's impacting initiation and engagement in the process of therapy as well. I think it just shows as well for me the importance about, say, my clinical intuition with these data-driven decision making. So, when we have that, the questions that come from being a clinician saying like, hey, I want to know more about this, getting this sort of data can then inform our clinical decisions in the future, can help us improve overall program effectiveness, but also knowing where we can allocate resources more effectively. So, for example, knowing people who have higher polysubstance use may need additional support, may need more of those resources allocated upon entry. And same with young people and those sorts of things. Obviously, some key considerations, like really just scratching the surface of what's going on when I talk about these 3 levels of predictors. We know that there's a huge range of biopsychosocial factors that would predict and interact to look at treatment outcomes. What I presented here didn't really go into depth around the dynamic way that those treatment factors may interact over time. And even what we did look at, you can see there were kind of nuances there that you want to be able to break down and look at a deeper level. And as I said, there's so many things that we didn't examine, like so much more I would love to do in terms of trying to just understand what is going on. Which leads me to my final point, which is, there is so much you can look at when we're doing this sort of implementation science and when we're evaluating new programs. And so what is actually helpful for us and me as a researcher to be looking at, coming from you as a clinician in the field? Love to hear your thoughts. Thank you very much for your time, particularly if you're in Brisbane and have a lot going on with the cycling. Really open for questions.
Thank you, Zoe. That was great. Lots of detail there for people to mull over. There were a bunch of questions from the chat, so I'll just ask them to you now. There was a couple of questions about, did you look at in your data like some potential adverse outcomes or harms that might have actually kind of resulted from engagement and treatment, so exacerbation or deterioration in mental state?
Yes, we did look at that. I'm just trying to think what we found, because I think some of the things that we were looking at was as well, if people stop in one area, do they get worse in another area? So if people are stopping one substance, they're more likely to take up another substance. If they stop in one area of substance use, the mental health likely to change. We didn't find any of that sort of adverse effects. The majority of people did improve their symptoms over time. There was some people who had no change over time and some people who did get worse over time. But the people who did get worse over time were the minority.
Cool. Thank you. There was another question, and I guess it's around, was smoking and vaping data recorded? And that question about whether residential services are smoke and vape free and whether that predicted sort of treatment engagement kind of outcome.
Yeah, that's a very interesting question and a whole other area we were wanting to look into. So the answer was yes, these residences were smoke and vape free. And they were smoke and vape free they were smoke and vape free with all the different projects, but the impact was different, interestingly, for the 2 projects that we focused on the residential. So with the full fix, that first project, transdiagnostic CBT for people who were entering the service, there wasn't any comments coming up from participants that the smoke and vape free environment had much of an impact. And that was the first study we did in that area. For grit, there was concerns about smoking. And subsequent to that, we implemented a healthy lifestyles program and did a whole evaluation following grit that really targeted smoking and vaping. And then we found improvements in smoking and vaping and people's outcomes. People weren't getting discharged for smoking and vaping and weren't leaving because of smoking and vaping, which we found was happening initially at grit. And then for the trauma-informed care, there was another shift. And I think that was because there was a greater impact of vaping at that time and a greater impact on the way the services were managing the smoking and vaping. And so we found that there was initially a huge decline of people leaving for smoking and vaping, and then that kind of crept up again when we did the trauma-informed model of care. And we're saying, okay, there's an ongoing issue here that clients and staff are saying, hey, we actually want to look at this again. And so I think that's an important next step, is like, okay, this is a kind of ongoing area.
Yep. Cool, thank you. A question was here, did you measure or were you aware the number of clients that may have had engagement with like a peer worker or a lived experience worker upon, say, entry, and if that had any effect on retention?
Yeah, we didn't have that data in any of these three studies.
Mm,
And that is a focus, I think, on some future projects that Lives as Well is really keen on running, kind of recognizing that, particularly with the areas when I'm talking about um, stigma, discrimination, the social factors, social belonging. One of the things I didn't report on was the social belonging
mm,
importance at residential services and how that's a predictor. I think these are all key areas that the peer worker really plays a massive role in. And I think would be really interesting to look at uh, just based on, what we know about the role of peer workers, how that would have a big impact on that treatment initiation, retention, and then outcomes subsequently.
yes, everyone's very interested in that.
Yeah.
There was a quick question, maybe to just a bit of a clarification about the transdiagnostic approaches. What were the three items or the three circles? Emotional regulation, and what were the other two?
Impulsivity
That's right.
and that social groups and belonging.
Three. Thank you. That's for you, Coralie. There was probably more of a comment, but there was some feedback around the use of feedback-informed treatment, such as ORS and SRS, has been quite successful in other kind of locations and jurisdictions. Have you used this in the past or considered this as part of your outcome measures?
Yeah, there's a whole project going on around the importance of feedback and outcome measures.
Mm.
Really interesting stuff. There's a Center of Research Excellence led by Leanne Hines. It's really focused on outcome measures and how we can provide that feedback in the way that provides it can have a big impact on these sort of treatment factors. So the short answer is yeah, it's being investigated. It's a huge area. I think it's super important. And I would just say watch this space. You'll have to get Leanne on to talk about it because it's really interesting.
Yes, excellent.
And thanks for the comment. I think that's really important to know.
Yeah, and I'll let Leanne know that you dropped her in that one. So thank you. Um, there was another question that's just come through around kind of focus on priority populations. So we're talking about trans and gender diverse folk, First
Yeah.
Nations, all culturally, linguistically diverse, and whether some investment in training and professional development for staff, whether that kind of capability building was factored in.
Yeah. It, I would say, wasn't factored in. And it was something that I was looking at initially as predictors and then realized we didn't have in our measures the right way of really getting at that sort of level of diversity based on what we measured at baseline. We weren't getting that kind of individual understanding of a person's
Mm,
background and diversity, as well as the therapist's understanding or the service providers understanding and training of it. It did come up a lot in when we were doing the training for the trauma informed model of care, because we know that that's a really important part of trauma informed care is recognizing that diversity and meeting people where they're at and having that kind of cultural responsiveness and safety.
mm.
And I think that's then subsequently things that are being incorporated into practice, but sadly not something we measured or I felt we had the right measures to do accurately.
That's all the questions we have online. So thank you to all of those people who submitted questions. There's some lovely comments in here too, Zoe, about the presentation and how well you went, and some appreciation for the effort you put into collecting it. So I think we could possibly leave it there for today. So thank you, Zoe. Appreciate you kicking off our 2025 semester with that very fascinating presentation.